Hello, Changemakers. It's Carrie Amato. Maternal health is a critical issue around the globe facing millions of women every day. According to the CDC, more than 60% of pregnancy-related deaths in America are preventable. And this is not just a women's issue, it's a humans issue. Accelerate Health is thrilled to be partnering with the Global Health Equity Network to host a tech challenge in an effort to source solutions to help address this crisis. On this week's episode, Indu Sabaya will be speaking with Dr. Ellen Seeley, Director of Clinical Research for Brigham and Women's Hospital, and Research Lead for Heart Health for Moms, where she's directing research of women who have experienced pregnancies complicated by preeclampsia and the important work that they're doing through data and education. Take it away, Indu.
So I'm so excited to speak with you today, Dr. Seeley, and the topic that we're going to spend some time on together is this issue of heart disease in women and some risk factors that you've spent, a good part of your career studying, and specifically this finding that complications during pregnancy, specifically this work around preeclampsia and gestational diabetes, could be, and in fact are, predictors of downstream heart disease in women. But this wasn't always obvious to the world. It was your work and some of the work of your colleagues that really put this on the radar. So I would love, in honor of kind of focusing on heart health in women, focusing on women's health, for you to take us a little bit through the journey of the literature and how we got to this discovery and how we got to these updated guidelines finally.
Sure. Thank you, Indu. And I really appreciate the opportunity to be able to talk with you about these topics that are dear to my own heart. Even from the 1970s, there were reports coming out that were linking having complications in pregnancy and future cardiovascular disease. So we probably knew the most first about gestational diabetes, which is a new onset diabetes in pregnancy, goes away with delivery, but it predicts up to a 60% chance of developing type 2 diabetes in the next 5 years if the person's, for example, obese. Type 2 diabetes is one of the most important risk factors for heart disease in both men and women. It is a particularly strong predictor of heart disease in younger women. There was that link, and that data started coming out in the early 1970s. What was happening was there was a parallel literature emerging about preeclampsia, which is a term people don't know about, as well as gestational diabetes. And it's new onset high blood pressure during pregnancy, but it's accompanied by signs that the condition is affecting organs throughout the body. So it damages the lining of blood cells throughout the entire body. So it can lead to seizures, it can lead to liver problems, it can lead to kidney problems, even dialysis. And importantly, it can lead to problems getting the right amount of blood flow to the fetus and the growth of the fetus. Reports similar to those in diabetes, in gestational diabetes, showing a link to future diabetes and heart disease started emerging with preeclampsia and future heart disease. My wish has always been that it's not going to take us 30 years to take advantage of knowing about this link. And I think some of the reasons it's interesting about, you raised a question about why is it that it takes so long, is that the pregnancy complication falls in the hands of the obstetrician. The long-term health falls in the hands of the internist or someone in internal medicine. It may be a primary care physician, it may be a physician assistant, but there's a big disconnect between what happens in pregnancy and what happens many years after pregnancy, such that the people caring for women many years after pregnancy often don't even know and don't know to ask about pregnancy complications.
So when did this make its way into the actual then guidelines?
Right. So in 2011, the American Heart Association, the American College of Cardiology put out recommendations for evidence-based care of women related to risk factors for heart disease. And it was the very first time that the pregnancy complications of gestational diabetes and preeclampsia were listed as major risk factors for heart disease in women, listed in the same category as smoking or a personal family history. And if someone were to see a patient and try to understand their risk factors for heart disease, and someone asked them afterwards, did you ask them about family history of heart disease? And they said, no, we never got to that. The listener would be shocked. How could you get a history of to counsel someone about heart disease and not find out if there was premature heart disease? At the same time, a lot of practitioners were seeing patients and not asking them about their pregnancy history. So in 2011, in those recommendations was embedded also a recommendation that all women should be asked about complications of pregnancy, and that it should be documented, and it should be used for risk stratification. In other words, who is at higher risk and who's at lower risk, and the women with these pregnancy complications should be considered at higher risk. And both gestational diabetes and preeclampsia were on that list. Despite them being on the list, we have data and other people have data that they commonly are not asked about, unfortunately. And one thing I'm hoping through avenues such as today and other avenues we're pursuing is how do we get it out there that pregnancy complications are a window into future health?
Absolutely. And just to give it some context, I think you shared with me when we had spoken in the past that it was up to 50% of women that were not being screened for type 2 diabetes when they had gestational diabetes. So you would get this complication in pregnancy that is so clearly linked to diabetes later in life, which is then so clearly linked to heart disease. And 1 in 2 women weren't being screened for that.
Exactly. And that was at an academic medical center. So we don't know what's happening elsewhere. And we say in academic medical centers that we are evidence-based, so that we're trying to use the best data available. And the American Diabetes Association has been saying for many years that any woman with a history of gestational diabetes should be screened annually for type 2 diabetes. If her test doesn't show any hint of prediabetes, that it could be switched to every 3 years, but the interval never becomes greater than every 3 years. And if it's abnormal, then it should be yearly. And I think that goes to what I often say is that no woman who had gestational diabetes should ever present with complications of diabetes, because we have good therapies to help prevent a lot of the complications. We may not be able to prevent all of them, but a first manifestation should never be with complications, because these are the women we should be picking up very, very early, and where we have a chance to prevent diabetes, or at least to institute therapies that have been shown to decrease the amount of heart disease and diabetes, such as the use of statins.
Absolutely. And I'm going to get to kind of how you mobilized your research and your work based on these insights. But before we go on, I just want to make sure people understand the scope of how many women get preeclampsia and gestational diabetes. And I believe you've put it at 12% of the population of women who've had children.
If you look at gestational diabetes, it's about 7% of the US population. And that's been increasing as the obesity epidemic increases, because obesity is a risk factor. Preeclampsia is maybe closer to 5%. And for unclear reasons, there's not a lot of overlap between the two conditions. So you might think, well, being overweight is a risk factor for both. Maybe the overlap is 90%, but the overlap looks to be less than maybe 5%. So that's where you get up to about 12%. And even if you say there's more overlap, you're still at maybe the lowest you're going to get is to about 10%. And that's 1 in 10 women having a pregnancy complication that gives her and her care providers a window into her future health that she wouldn't necessarily have, that can be utilized to decrease her chance from developing future disease. And we always say it's a wasted window of opportunity if that link is not made by the provider, or sometimes the woman finds the link by looking at the internet, but the provider needs to be able to follow up on it and give the woman advice about what she can do to lessen her risk of future heart disease.
So you took this sort of observation, of the literature from the 1970s, the fact that no matter how hard it was being promoted, that, 1 in 2 women still weren't being screened, and you've now sort of shared.
We did a couple of things. We said we can't be dependent on the providers alone to be letting the women know about links between their pregnancy complications and future heart disease risk. We still want the providers to learn, and we haven't given up on that. But one way is we're reaching out to the women directly and educating them about the link, and then having them educate their providers. The other part, so that was one principle that we thought was important, is a lot of campaigns about public health are based on provider education. The providers should spread the word. So we said we wanted to focus on the women with the conditions themselves and let them be the advocate for the education, broader education. The second we said is that we know that we can decrease risk in general for heart disease by lifestyle change. And the impact can be really large. So for example, lifestyle change can reduce the risk of diabetes by over 50%. That's as good as any medication we have available to reduce risk. If we want this group of women to receive information and to learn how they can reduce their own risk, they first need to be aware of the link, because otherwise they wouldn't even think there's someone who has to adopt any changes. And then they have to have a way of adopting changes that fit with the life of someone who has a recent child. It became apparent that the model of face-to-face delivery of information was not going to be a viable model. And I'd say that for 2 reasons. One is that when you talk to primary care physicians, they're overwhelmed by how much they have to cover in a session. And a lot of the preventive health that they're very interested in, and maybe the reason why they went into primary care, they can't do due diligence in the limited time they have to be sure all the vaccines are given. And we're talking pre-COVID even. If you offer additional sessions at health centers for women to come to, women have an incredibly high no-show rate in the several years postpartum because of the other demands that they have, traditionally being more greater than their partners, than in terms of the care of children or other children at home and the care of the home. What we said is we were going to move the education directly to the women, and we were going to do it in a way that they didn't have to go anywhere, that they could get it right where they were at home or previously at work. And we were going to do that by having everything available for them to teach them education to change their lifestyle to a healthier one, and the motivation to change their lifestyle, and to reward them for changing their lifestyle, and do it all via mobile health. And what is interesting is, for example, one of our modules is how to talk to your provider about your pregnancy condition. And that's often the education of the provider. So we give references in that, and the woman fills out part of it herself and brings it to her provider. And we figure if one provider is educated by one patient, they can apply that to all the patients they're seeing with a pregnancy-related condition. So the study that you and I had talked about was the study we called Heart Health for Moms. And it was designed with the input of the Preeclampsia Foundation, which is the largest organization of survivors of preeclampsia. And every step along the way, representatives were involved in the design of the study, the design of the website, the materials on the website. And we designed it so that it would educate women about the link between preeclampsia and heart disease, and then give them tools that they could actually apply in their lives to decrease their risk. And the lifestyle changes being small but additive, because behavioral theory shows that if you succeed in one change is small, your confidence in achieving the next change gets magnified. Tracking of weight, for example, has been shown as being reinforcement, and that it's all available via the web. We made it so that since most people don't use PCs necessarily to access the web, we made it so that it is compatible to mobile devices such as a tablet, iPad, or iPhone, or Android phone. So it's completely not distorted when you look at it. And it means that the woman can look at it any time of day or night. And we had, in the studies we've used using this kind of mobile health approach, women are using the materials 24/7. So there's no time of day or day of the week when women aren't using it. So it may be at 3 a.m., they have a sleeping newborn where they had preeclampsia during that pregnancy, but their 2-year-old wakes up with a nightmare. And when they're trying to go back to sleep from after they've comforted their child, we have women who would put on a module to listen to. Another example of how it's compatible, so it fits in their life instead of taking them out of their life to do it, is we do both audio and visual narration, so that we had one woman whose husband put on every night when she was making dinner, he put on a different lesson, and she listened to it while she was making dinner and was able to learn, and it enabled her to actually make changes in the way she was cooking her dinner by listening to some of the modules about meal preparation. We are using evidence-based practice for the recommendations. So for example, we use the balanced plate. And then what we say is that the woman can cook using the theories of the balanced plate. She should then make her own balanced plate. And then when she makes her own balanced plate, one thing, for example, to try to engage the family would be, as a game, she could have her children try to make a balanced plate. And we have a printout of the balanced plate that can be put on the table so the kids can engage. So we really wanted to make it a family-based intervention. And we had people talking about how their husbands lost weight during it, how one person's son's cholesterol went into normal range. So we were able to see that there was a family. But I really think it was bringing the behavior change into someone's home instead of you're bringing it to where they have to make the behavior change, which is very different than having them say, yes, I'm going to do this sitting in a nutritionist's office.
And I think the other insight that's been so, I mean, I really love this idea of you kind of having flipped the model on its head, and instead of going through providers, going through actually, the women themselves, the people affected by the condition, and having this sort of reverse training of the healthcare workforce, and also meeting people where they are in their lives, and so something can sort of suit their lifestyles, acknowledging that moms are busy, and especially in those sort of immediate months and years after a child is born. So I think I really commend you on those insights in designing this intervention. I think one of the other insights, I think, is that going through preeclampsia is a pretty scary thing. And, I think you were sort of saying that these women don't necessarily relate to sort of more general pregnancy support groups that are just about lighthearted things, and that there's a degree of investment,
right,
their health, because they've been through something life-threatening. I think that's really interesting that you're coming in to this group, catching them when they're the most engaged, and saying, okay,
yeah. I think what's very different about a complicated pregnancy is, for example, gestational diabetes and preeclampsia. People have the opportunity, I'm not saying it's a good opportunity, but they are exposed to the opportunity to experience a negative health condition. And so many of the women who experience them have always been healthy. They may see poor health in a family relative who's older and it's often removed from them, but they actually get to live a health condition and see what it's like. For example, in gestational diabetes, a number of women go on insulin, they're doing their finger sticks, they're following a diet, they're doing what anyone with diabetes, permanent diabetes would do. They get to live it, and then they get to afterwards say, I've lived it, what can I do to prevent it? Preeclampsia, as you mentioned, is much more sudden in onset, and there's much more risk to life, both of the mother and to the fetus. So it's much more serious than gestational diabetes is. Not to minimize the impact that gestational diabetes has on a woman, but their view of talking about their pregnancy, and especially after pregnancy, talking about their pregnancy, is so different than someone who was saying it was so great seeing the next ultrasound or going to the doctor and seeing how the baby was growing. So we provided community forums for both groups of women when we studied them. And the women really appreciated being able to tell their own story of what happened to them. And that was often the first thing that was the most important, because women their own age are not experiencing, I mean, most obviously people can have adverse health events at any point, but in general, women in their 20s and 30s, which is still, what we consider childbearing age, are not having serious health events. And these are women who experience a serious health event during pregnancy that does make them feel different than the other women they might find in before, when they could go to play groups or meet in the park. And it often makes them very isolated. So for them to be able to communicate with other women who had something similar is very empowering for them. And then it helps them have that confidence to make the behavior change, because they don't feel like they're alone.
And this downstream, as a woman who's heard about kind of the risk of heart disease and that it is a leading killer in women, and I've heard this my whole life, but when you're young and everything is, you seem relatively healthy,
right,
it is very hard to wrap your mind around kind of engaging in preventive behavior. And I think the field of preventive medicine, I think, struggles with this idea. And here you have a window of opportunity to get somebody in their 20s and 30s that might have otherwise been neglected by the system for another 20, 30 years. And by that time, it being too late.
Right. And I think preventive health in general being a challenge, but we believe it will be less of a challenge in this population because of the fact that it's not something abstract. It's something that has affected them, and we can give them odds of them developing the condition later in life. And they've experienced, so it's, for example, developing high blood pressure in life. They've experienced what it is like to check their blood pressure and see a very high number that makes them worried. And I think it's very different to do preventive health in the situation where someone's experienced the condition. At least that's what we're hoping, that will give us a better way in to get the behavior change that can clearly reduce heart disease in women.
So from an outsider's perspective, I think of this as so obvious, and that this need to reach this population, to have this impact, it's powerful. It's a large section of the population of the country as a whole, and the world if you were to go beyond. But what barriers have you encountered in scaling your intervention outside of Brigham and Women's and the community in Boston? Tell us a little bit about those barriers, and then what do we need to do as a community to raise awareness so that no woman that has a pregnancy complication that puts her at increased risk for heart disease later in life is left to herself, and that we catch everyone we can.
So I think that's a really important question, and it has answers on multiple levels. So one is that people are still so unaware of the link that it's very hard to get people excited and mobilized about something they don't know about. So it means that you need to have some kind of platform to explain it, because if it comes across as just women with this condition have increased risk, it sort of fades among everything else. And often there's not the platform to explain. So we already know that a lot of primary care providers are not aware of the link. If they're not aware of the link, are they going to be advocating for programs that are going to help prevent the women who had the condition from progressing? Probably not. If the health administrators in a hospital system are not aware of the link, are they going to be advocating? One of the problems we have with our health system is that the healthcare system that takes care of you in your 20s and 30s may very well not be the healthcare system that takes care of you when you manifest your heart disease in 50s and 60s. So is there the incentive for our health insurance companies to invest really in preventive medicine if the condition is going to present when there's a good chance they're going to be under another provider? And it's passing the buck, but we're very aware that it happens. One of the other things that has happened is that there's obviously what you need to do in pregnancy to treat the woman who has gestational diabetes or preeclampsia. And there is a lot of effort that goes into taking in funding in that area. And it's almost as if people are on one side or the other, and it's not integrated. So the funding announcements that come up for improving things in pregnancy may go to complications that occur within a couple of weeks after delivery, but they're not going to go often to things that happen 5, 10, 15, 20 years after delivery. So I've always argued, we have a lot of brain power, and there can be people working on how we cannot have preeclampsia occur in pregnancy, or what is a better treatment for preeclampsia, because the only treatment to date is delivering the baby. That doesn't mean we shouldn't also be working on, if someone had preeclampsia, how we can prevent her from having an early death from heart disease. But often people are on one side or another, and I think it needs to all be integrated, that there are certain things that happen in the lifespan of a woman that are different than in men, and pregnancy still is a woman unique condition. So pregnancy, the complications of pregnancy can be seen as enduring past delivery, and that we need to focus on what happens after delivery and what happens during the pregnancy itself. And I think it's been fragmented by our healthcare system because different providers take care of both. It's been fragmented by funders because funders fund one or the other. And there's more attention on the pregnancy because there's an immediacy to it.
So, yeah, I mean, absolutely. I think the idea that what you've proven in the model you've already executed, though, is that when you use a mobile platform, if you use technology that's personalized to these women in their lives, you're not only impacting everything we've talked about, you're impacting the health of their family, you're impacting their children and their partners. And so I do believe you're right. There is a catching up that the healthcare system and the way we fund things has to do with the way technology, when it's done right.
Right. I think that's a really good point. And when grantors give funding, they often give it narrowly. So in our studies, for example, we know, because we do qualitative work and we interview people, so we have reports about impact on family members that we know are significant. And we use the analogy of a woman keeps her body healthy. On the whole, there's a lot of motivation to keep one's body healthy when one's pregnant, because that's the home of the baby. And what we say is keep your home healthy while your children are growing up, because that's the environment that they're living in. Put the same effort into it as you put into, when you were taking care of your body during pregnancy. What happens is funders give you a certain amount of money and you have to answer your primary question, and you have to have enough numbers of people to be able to answer your primary question. So, for example, in the study where we wanted to look at the impact of other family members, we said, one thing we could do is have other family members weigh themselves. You do need additional money if you're collecting additional data. And it seems like in some ways such a wasted opportunity, because all the money goes into the structure of the study and you have the near potential to capture family impact. But because the limit on the grant is whatever it is, you can't capture that. And that's been one of the frustrations that we've had with this.
So, Dr. Seeley, I just want to thank you for bringing this topic to us today, because I hear a lot in what you're saying about the awareness we need to raise, the funding we need to scale, a program such as yours that you've designed. If you had to wrap us up today with kind of a call to action for those listening, and those listening might be providers, they might be technologists, they might be moms, or family members of somebody going through this, what are some of the calls to action that you want to put out to the community, and how can we help you reach every woman to reduce the risk of heart disease in America?
Yeah, so I think when you mention the diverse audience, it's a diverse group that we need to increase publicity about the pregnancy conditions and their long-term implications. Letting it be something that medical providers are in charge of, if it works, it's really delayed in terms of how long it takes to work. So we need everyone involved, and we need everyone talking to each other and to people, that they're friends with, and people, if people talk about their own experience, which sometimes is challenging because it feels private, that can be one of the most compelling ways to have an impact. So I think we need everyone joined together, and we need to think of it as not separate groups advocating for separate needs, but how we can put the groups together as a collaboration so that we're getting technology to help deliver interventions that are going to be beneficial, but people involved in PR who can help get the word out and come up with creative strategies to get more people aware. We need people who advocate for government, in government agencies and do advocacy work to get different things funded. We need people talking to the insurers so that what happens after pregnancy is covered. A lot of insurance stops at 6 weeks after pregnancy in other states. So I think we need the team. And I think short term, what we need, that's sort of the grand picture, is a large team working together. We had a meeting where we put together stakeholders of patients, as well as providers, as well as people in national organizations, to have a conversation among multiple groups. And I think those are the conversations we need to have to come up with an organized plan. I think technology can do a huge amount in terms of spreading the word, as well as delivering ways that women can change. So we're looking right now for Heart Health for Moms. We developed it. It was successful. It's for women who had a recent history of preeclampsia. There's nothing out there. Whenever we present it as a talk, people say, can I start using it? And I've had physicians who had preeclampsia asking if they can start using it. We have patients who say they can start using it. Healthcare systems, can they start using it? And with relatively little funding, we can move it to a state where it can be usable. So for example, looking at this point we're at now is what kind of agencies would fund something like this, where the discoveries in some ways have been made, and now you need to make it available. And how making it available and making it accessible to many women should be as exciting as figuring it out. But often the excitement ends, unfortunately, with figuring it out. And there's a lot of research that's been done as we have all this evidence-based research and it's not implemented. And why is it not implemented? And part of it is because there's not financial support for the implementation part of it. So in terms of advocacy to funders, I think, I certainly would advocate for funding implementation of projects that seem to have promise.
I think I couldn't say it better, Dr. Seeley. So on that note, we really applaud you for standing by this idea of translating discovery to the last mile into the lives of people, because that's what matters. That's what we're all in this for. So really proud of the work you're doing with Heart Health for Moms, and thank you so much. And we hope you carry on and find the support that you need to reach.
Thank you. Well, thank you for this opportunity to talk to the audience, and I appreciate the audience for listening. And I hope that they have a way to send in ideas that they have to some email or website, and maybe we'll get some great ideas from this podcast.
Fantastic. Thank you so much.
Thank you, Dr. Seeley and Indu, for that inspiring discussion. The mission of Accelerate Health is to catalyze and guide innovation insights and technologies needed to transform care delivery and drive what's next for health. That is why we've partnered with the Global Health Equity Network to launch the inaugural Global Maternal Health Tech Challenge for 2021. We'll be making 4 stops in North America, Asia Pacific, Latin America, and Europe that will culminate in a live final pitch competition in Las Vegas at the HIMSS Global Conference, with the top teams from each region presenting. We are looking to crowdsource solutions that address barriers in care coordination and/or behavioral health, and that can be implemented to improve maternal health across the globe. If you have a tech solution that can help save mothers, we want to see it. Submissions for North America close on March 15th. Go to hims.org/events and search Global Maternal Health Tech Challenge. Until we chat again, keep on accelerating. Thank you.